Hi, and welcome to Complex Coronary Interventions from the Leeds Infirmary. This is a case of a complex right coronary chronic total occlusion treated with a combination of retrograde reverse cart and rotational atherectomy. My name is Dr. Abdul Moses. I'm a consultant cardiologist at the Leeds General Infirmary. So this was a 72-year-old man who had undergone previous coronary bypass surgery with lumen to LAD and vein grafts to his PDA and obtuse marginal. He presented with CCS class 3 angina, and the perfusion imaging showed infiltrative ischemia. His coronary angiography showed patent grafts but an occlusion of the RCA-PLV branch, and he had persistent symptoms despite medical therapy. This was his previous coronary angiogram showing occluded left main. This is the native right coronary artery showing a heavily calcified vessel with proximal occlusion. This is the patent graft to PDA, but you can see there is a severe stenosis into the PLV, which is then occluded. Just here, there's a subtle occlusion of the PLV also. This is a patent graft to the circumflex system, and this is a lemur to LAD, and you can see filling of the PLV branch from the distal lemur. So this was the target for intervention, and he was admitted electively for this procedure. This was performed using biradial 7 French access, and the strategy was to first open the mid-RCA using retrograde reverse cart by the graft, and then perform antegrade wire escalation to open the PLV branch. So this was biradial 7 French. We initially performed dual angiography from the vein graft and from the lemur to clarify the distal anatomy. And so here, this does clarify that there is a occlusion of the PLV branch, which will need separate antegrade wire escalation technique. After the native RCA is recanalized, the graft to the PDA is nice and healthy with good distal PDA. Here is another view, dual injections from the vein graft and the lemur. This again shows a short occlusion of the PLV branch. The right coronary artery is heavily calcified throughout its course, as you can see here. So this is dual injections from the graft and the native right coronary artery. This was a multi-purpose guide catheter from the left radial and an AL1 guide catheter from the right radial. And you can see heavily calcified right coronary artery with a short occlusion in the mid vessel. So we went straight for a retrograde approach to recanalize the mid RCA. This was a retrograde Mamba Flex 150 microcatheter, and you can see here with initially with a cyan black wire, because of the acuity of the angle, the microcatheter and the wire prolapse. So I then took a Miracle 12 wire, which has nice support from the tip of the wire, which transitions to the core of the wire to the shaft, and this then allows you to deliver your equipment on the wire when you have short working distance such as this. So here with the Miracle 12 delivered, you'll see initially prolapse, but then once it's brought back, it then allowed the Mamba Flex to negotiate this angulation. The Miracle 12 was then removed and performed retrograde wiring with a Pilot 200 wire. This crosses the tight stenosis from the PDA to the RCA. It isn't possible to advance the Mamba flex catheter. The pilot 200 is then crossed through the occlusion, and the Mamba flex advances easily. The Mamba catheters are very torqueable and have a tapered coil and integrated tip design, which optimizes flexibility and crossing profile. So here we then come to the true occlusion point, taking an antegrade picture. With antegrade picture, we can see that we are very close at this point to crossing. However, it is not possible to redirect the pilot 200, which is clearly in a subintimal plane. And here we are again wrapping around the vessel, and this is clearly subintimal. Confirmed antegrade injection. So leaving the retrograde equipment there, we then attempted antegrade wire escalation with a Mamba Flex 135. And this is again attempting with a Gladius wire now, antegrade, and unable to cross occlusion. And you can see it is then very difficult to even start a knuckle to try and overlap dissection planes to perform reverse cart. We tried again with a Fielder XT wire to try and form a knuckle, to try and have both wires overlap in the subintimal space. Again, it's very difficult to get a knuckle started. There are several options at this point. We can take stiffer wires, either retrograde or antegrade, but this can lead to issues with stiff wire perforation. So one of the safer things to do is to perform deliberate dissection, and this is performed using a balloon, so-called balloon-assisted subintimal entry or BASE. So here is a 3mm NC balloon inflating the proximal vessel. You can see the wire there enters the subintimal space, and the Mamba Flex is advanced with it. So here clearly you can see that there is some lucency between the wire and the balloon, and that's clearly in the subintimal space. And the Mamba Flex catheter is able to easily advance into here. And then with the balloon inflated, this then provides a coaxial anchoring balloon, or also known as power knuckle. And with that inflated, this gives a very stable platform to perform antegrade knuckling. And we check in two different views. And here in REA, you can see that the antegrade wires overlap with the retrograde equipment. The antegrade Mamba is then advanced, and we now have good wire position and very close to the retrograde equipment to perform our reverse cart maneuver. So we're now set up for reverse cart. So we advance a 7 French guide extension, in this case a Guidezilla. We inflate the proximal tract to allow delivery of the guide extension catheter. And this is the inchworming technique, where the guide extension catheter is advanced over an inflated balloon. You see this. So this is a very good, nice sign when you can see movement of the wire and microcatheter on balloon inflation. As you'll see here, this tells you that you are in the same space and essentially connected. And it should be very easy then to perform your reverse cart. And in fact, after that, you can see that the wire is very well aligned now. So the balloon is removed. And then attempted to wire the guide extension, which is relatively easy. The guide extension is then wired with a Retrograde Pilot 200. The retrograde wire is then trapped with the balloon in the Antegrade guide catheter, which then allows the Retrograde Mamba flex to easily advance into the Antegrade system, as is demonstrated here. As you can see, the Retrograde Mamba advancing into the guide. And following this, the retrograde part 200 is removed and wire externalisation is performed, in this case with an RG3 wire. This is a 300 centimeter wire, specifically used for externalisation. After externalisation, the retrograde microcatheter can then be withdrawn. It is always important to keep an eye on the retrograde guide catheter, as this can be sucked in quite deep. We then pre-dilated the occluded segment. This is a 2.5 by 30 millimeter balloon. It's very useful having long balloons for this type of CTO work. The whole track is dilated. And then the Guidezilla extension catheter is delivered over the balloon. Some more preparation with a 3 millimeter NC balloon to allow deeper engagement of the guide extension catheter. That was demonstrated here. So this is the inchworming technique, demonstrated nicely, of how to deliver a guide extension catheter. This is very helpful in heavily calcified vessels. So we've now opened the mid-right coronary occlusion. So we then used a Twinpass lumen catheter. So the retrograde microcatheter is pulled back over the RG3 wire into the vein graft. The Twinpass lumen catheter is then delivered antegrade over the RG3 wire through the occlusion into the graft. And then a cyan blue is passed out. And this, in fact, was advanced easily into the retrograde guide catheter in case there was need for anchoring techniques. So once we now have antegrade control over the PDA branch, we can then remove the Twinpass lumen catheter. In this case, we used an extension wire, as it is difficult to perform trapping in the 7-phase guide extension with a Twinpass. So here the Twinpass is removed using an extension wire. The retrograde Mamba is then re-advanced into the Antegrade guide and the RG3 wire removed. And the retrograde Mamba catheter is also then removed. So we then switched our attention to attempting antegrade wire escalation to open the PLV branch. So a Mamba Flex 135 was delivered antegrade using a cyan blue. We know from previous angiography that this portion of the vessel is patent, albeit with a severe stenosis. And we are then able to negotiate this diseased area with the cyan blue. So the antegrade Mamba flex was advanced to the occlusion point. We then removed the retrograde multi-purpose guiding catheter and exchanged this for a IMA diagnostic catheter to image from the lemur to show us the distal PLV vessel. So here is the retrograde picture from the lemur. This then demonstrates the PLV branch, and in fact the competitive filling suggests that the occlusion is in fact likely functional rather than a true occlusion. As you can see, the to and fro movement of the contrast, suggesting improved antegrade flow after we've already opened the mid-vessel occlusion. So we then performed antegrade wire escalation with a Gladius wire. And in fact, this was fairly straightforward. And here again is injection from the lemur, confirming that the wire is in the true lumen. Then advance the Mamba flex, and you can see that the vessel is heavily calcified and there is a lot of resistance. And this is one of the advantages of the Mamba catheters with the integrated tip. See here, talking of the Mamba, and it makes a little jump there and finding some progress through the occluded segment. But certainly there was heavily calcified disease at that point. As the Mamba had crossed the occlusion, I thought it would then be possible to dilate the lesion with conventional balloons. So we exchanged the Gladius to a workhorse cyan blue wire. This is just a cyan blue into the distal PLV. The Mamba was then removed, and interestingly, it was not possible to advance even a 1 millimeter balloon through this calcified angulated segment. You can see here, despite pushing with the guide extension catheter, this is as far as the 1 millimeter balloon would pass, and you can see the guiding catheter being pushed back. So this is somewhat surprising, as usually if a microcatheter is able to cross, a 1 millimeter balloon will usually follow. And this, I think, gives some indication of the unique properties of the Mamba catheters, enabling to cross calcified lesions where other devices are not able to. So we tried a variety of balloons with no success. And here again, you can see pushing on. Absolutely no luck. So I then took the Mamba Flex back, and again, torquing the microcatheter, I was able to advance the Mamba through the occluded segment again. This is where 1 millimeter balloon had not been able to cross. So then switched strategy and proceeded to exchange the cyan blue wire for a Rota floppy wire in preparation for rotational atherectomy. So this is then Rota floppy wire being delivered. And subsequently the microcatheter and guide extension catheter were removed and proceeded to rotational atherectomy with a 1.25 millimeter burr. So initially we performed high-speed rotational atherectomy to the proximal to mid RCA. We gave 600 micrograms of atropine at this stage. As is our routine practice, we do not use temporary wires routinely, as any heart block is usually short-lived, and actually giving some atropine up front prevents that from happening. So this is following atropine. You can see easy passage of the burr in the proximal to mid to distal RCA. However, we have run out of length on the Rota system, so we then perform the Dynaglide maneuver to advance the burr more distal, which will then give us more length to perform rotablation to the distal vessel. So this was difficult due to the calcification, and performed deep seating of the guiding catheter with the patient performing a held inspiration. And with this, I was able to advance the Rota burr on Dynaglide to the distal RCA, and following this, we performed further rotational atherectomy into the PLV branch, as here. So here we are, a couple of passes in, the Rota is then able to cross. So a successful rotational atherectomy was performed, and this was then removed. And the Mamba catheter was delivered again and exchanged easily for the workhorse wire, which is in cyan blue again. And this was removed using a trapping balloon. And following this, the guide extension catheter was delivered again, and the vessel was pre-dilated. And so this is a 3.5 NC balloon showing good expansion, delivery of the guide extension catheter, guide 0 in this case again, to the distal RCA. Good expansion there. The PLV was then dilated with a 2.5 by 20 balloon, again showing good expansion. We then performed intravascular ultrasound imaging with the Opticross catheter, which crossed very easily, and this demonstrated a good size distal vessel measuring 2.75 millimeters in diameter and a large proximal RCA. So we proceeded to stenting of the distal RCA with a 2.5 by 48 millimeter stent at high pressure. You can see a good expansion of the stent. Placed another overlapping stent from the distal to mid RCA, another 48 millimeter stent, 3.5 millimeters in diameter, again deployed at high pressure. Followed by another 3.5 by 48 to the proximal RCA, and finally a 4 mm stent to the ostium. The ostium was flared, and the guide externalisation catheter was redelivered. And this is the first angiogram following this, showing a patent vessel. Then performed 3.5 and 4 mm post dilations. From the distal to ostial RCA, and 2.75 mm high pressure post dilations distally in the PLV. Following this, we performed repeat imaging to guide us on need for further optimization, and this in fact revealed slightly underexpanded stent in the distal PLV, requiring further post dilations, in fact with a 3 mm NC balloon. And this was then a 3 mm NC in the PLV branch at high pressure. And this is an important learning point on the initial angiographic images. One would feel that the PLV would be at most 2.5 mm vessel, but here you can see we're now post-dilating this with a 3 mm NC balloon, and the proximal vessel was optimized further with high pressure 4 mm NC balloon inflations. And here is the final result, showing an excellent result with a patent right coronary artery PLV. The vein graft to PDA is patent, so we did not pursue opening this branch. And an excellent final result. Thank you for joining us for this case presentation.